for the age group 35 to 44, there's a report from the Brookings Institution that just came out this week that showed the risk of dying is 10 times more for Blacks and 8 times more for Latinx compared to non-Hispanic whites. For ages 75 to 84, the risk is 4 times more for Black and 2 times more for Latinx. Regarding the use of masks, a study that looked at the daily growth rate of COVID cases in states that mandated face mask use showed a decline in the growth rate over time after the mandate was placed, further confirming the effectiveness of mandated face mask wearing. Yesterday, in part due to the large increase in the number of cases, California has now mandated mask wearing in most public situations. On the treatment and vaccine front, the biggest news of the week is that dexamethasone, which is a steroid drug, decreased mortality in severely ill patients with COVID. This is a study from the UK, and the results were not published via research reviews, but through a press release. So it's cautionary that we don't really know exactly how good the study is, but the findings are very impressive. Dexamethasone, just to remind people, is not a cure for COVID because it does not actually remove the virus directly, but it actually decreases the body's inflammatory response to the virus. The study randomized 2,100 patients to dexamethasone and 4,300 patients to usual care with a dose of 6 milligrams once daily for 10 days or to the point of discharge from the hospital. For those who were in the hospital but not on oxygen, the drug did not reduce any mortality, but it did reduce the risk of death among people on oxygen by 20% and those on ventilators by 35% for an overall mortality reduction of 17%. This is really great news for those who are very sick with COVID. The drug is cheap and readily available. I was asked to finish with a few comments on imagining the future of health and public health after the pandemic. As the saying goes, we shouldn't waste a good crisis. Out of this, there must come some good. I have been arguing for years that we have approached healthcare and public health the wrong way. We usually address the health for the average or default person who just happens to be white, English-speaking, employed, and well-educated. Then we look at health disparities as an afterthought. This was never going to work as a path for the future because by 2045, non-Hispanic whites will no longer be the majority. The COVID pandemic has accelerated its timeline by pointing out the terrible price paid by minorities as a result of building our healthcare and public health system on the racist principle of what works for white people. My slogan for this is there is no healthcare or health quality without equality. Any system that has disparities is a system that lacks quality. The disparities have to be addressed first, and then the quality will rise. The second good thing that I hope will come out of this pandemic is that we will fully address what we call the structural and social determinants of health. We spend way too much in this country on healthcare for the outcomes we get. We are the most expensive healthcare system on the planet and have the worst life expectancy among comparable countries. The reason is we spend money on the wrong things. The factors that contribute the most to low life expectancy are income inequality, low levels of education and exposure to violence, along with other key determinants like job, housing and food insecurity, and climate change. These are the proper topics for public health and for healthcare to work on in the future. And I will finish with one last thought. Vaccines should be mandatory. There are metrics for healthcare quality that looks at disparities. And that only works when those metrics are broken down by race and ethnicity, right? So when you have an average healthcare quality metric, like say, for example, the number of people with hypertension who has blood pressure control, and you don't break it down by race and ethnicity, that won't work, right? Because you'll just see an average of it for everybody. And so what we're asking for is for people to report quality by race and ethnicity. That would be a good start. I think there are national measures of quality that don't actually incorporate that. And so I think we need to make sure that, for example, the HEDIS quality measure of care addresses racial and ethnic factors.